Good morning. I'd like to call the joint oversight hearing to order. We have the joint oversight hearing today of the Assembly and Senate Committees on Health on the issue of do MediCal rates ensure access to care. I'm Rob Bonta, very honored to serve as the chair of the State Assembly Health Committee and overseeing this joint hearing today with my colleague in the Senate, Dr. Ed Hernandez, the chair of the Health Committee in the Senate. And I just want to thank everyone for being here today. I know that all of you who will be speaking today have been very involved in the MediCal program, and the first thing I want to say to all that are here are congratulations for helping with the important job of expanding MediCal in California. DHCS, thank you, all the stakeholders, even the critics who have helped expand MediCal. A couple of quick points I want to state to help frame our discussion and dialogue today. The estimated MediCal budget for 2014-15 is over $90 billion. Just 4 years ago, in 2010, it was a $50 billion program. Enrollment will soon reach 12 million individuals. 4 years ago, it was 7 million. MediCal now covers about 1 in 3 Californians. MediCal rates are still far below the national average for other states' Medicaid programs and also well below Medicare and commercial insurance. Given that growth in size and in scope, we must pay more attention than ever to rates. And I see this hearing as one of the first steps the legislature needs to take in order to ensure that we pay an appropriate rate for the MediCal program. And we just came from a press conference on 2 bills, one that Dr. Ed Hernandez has introduced and another that I have introduced regarding increasing the MediCal reimbursement rate. I think those bills are also a very important step. So at this point, I'd like to turn it over to my colleague in the Senate, the chair of the Senate Health Committee, Dr. Ed Hernandez.
Thank you very much, Mr. Chair. I appreciate the opportunity to just say a few words. First of all, again, let me thank all the participants who are going to be here this morning, obviously the department chairs as well, and all those who've flown up to testify. I'd also like to take this opportunity to thank the chair of the Assembly Health Committee for hosting this hearing jointly, but more importantly for also agreeing to carry the similar bill on the Assembly side as we have this discussion, this very, very much needed policy discussion. I will say he mentioned that we did have a press conference, and I was extremely impressed because I didn't hear this story. He was talking about his father and his mother, how they were farm workers and how they organize health clinics out with the United Farm Workers, and I was just really, really impressed. And he understands the need for health care for the most vulnerable. For me, this is about not just about rates and increasing those rates. I mean, we can talk about all the numbers in the world. For me, this is about access to care for the absolute most vulnerable population. And as the Assembly member mentioned, 1/3 of the population now is on MediCal. And fewer providers are taking MediCal, taking new patients, and it's becoming extremely difficult for patients to access care. And I've said this over and over again. What good is it to have an insurance card if you live in South Central Los Angeles, if you live in Oakland, if you live in Salinas, if you live in McFarland, if you live in the poorest communities, if you cannot get access to the absolute basic need and care? And for me, this is still about a 2-tiered healthcare system, one for those who have the means and one for those who don't. So I just wanted to thank you for allowing me to just say a few words, and I'll just turn it over to the chairman of the Assembly Health Committee. Thank you.
Thank you. I want to thank my colleagues in both the Assembly and the Senate for being here and participating in this important discussion, and want to now open it up for an opportunity for any members who wish. You don't have to, but if you wish to make any opening remarks on this topic. Please. Mr. Lackey.
Okay. I just real briefly want to say that I was raised in a very small community, Boron, California, which is actually a borax mining town that's about an hour away from any kind of services. We used to have our own community hospital. That's no longer the case. So I just want to make sure that we as a body make sure and ensure that those people that live in those kinds of communities, that we have rates that are high enough to ensure that health care access extends to each one of those. As the Senator clearly put, it doesn't do you any good to have any insurance if you have no provider that's able to provide you what you need. And in many cases, these are life-threatening circumstances. So I just hope we keep in mind that rural America is also struggling.
Thank you, Mr. Lackey. Any other members like to make any remarks at this time? Mr. Thurman.
Thank you, Mr. Chair, and thank you, Chair Hernandez. Thank you both for calling this meeting together, and to all the members who are here today for lifting up this issue and how important it is to both urban communities and rural communities, as my colleague, Mr. Lackey, has just pointed out. Sadly, I'm going to have to leave this meeting very soon because we're having a meeting today to talk about a hospital that mostly serves MediCal patients and that is on the verge of closure within weeks, if not days, purely because the patient mix is one where only 10% of those served have any insurance. 90% of those served are MediCal, Medicaid, or no insurance at all. It's called Doctors Medical Center. And it serves 5 cities in a community that has very high poverty rates, and it's the only emergency room in that entire area. So I say that to say how many of our communities are deeply impacted by this. It's very important to me, and I really want to thank the chairs for lifting up this as a topic and for your legislation, which we're certainly excited about, the potential to make a change. Because as our chairs have both said, if you don't have health care, what do you have? If you don't have your wellness and your vitality, what do you have? So I'm looking forward to the conversation and the presentation today and the work that we can do together to lift this up. Thank you very much.
Thank you, Mr. Thurman. Dr. Pan? No? Okay. Mr. Wood.
Yes, thank you, Chair, and for the opportunity. I just want to highlight, I'm a healthcare practitioner. I practiced in a small community in rural Northern California, and now I represent that community and several other counties that are equally rural and in many cases very poor. Indeed, Del Norte County, one of the poorest counties in the state, is now in a position where there are no DentaCal providers accepting new patients. So we have created an access issue where we have expanded the population of people who have access to care that does not exist, and it's clearly a step in the wrong direction in my opinion, and something we really need to look at. Healthcare is not about it shouldn't be. I don't believe it should be a line item. I believe that healthcare is one of those things that is a foundational piece for how we get along in society. Healthcare impacts how we are successful in our education. Healthcare impacts how our economy is successful. You cannot have a good, healthy, solid, well-trained workforce without basic healthcare and good education. And the foundation for that is healthcare. And I hope that we move forward on bringing the rates that are commensurate. It's not about, for practitioners, it's not about making money on this program. It's about not having to give so much away. And I'll have more comments about that as we go forward. Thank you very much.
Thank you, Mr. Wood. Ms. Waldron?
Thank you, Mr. Chair. Just briefly to tag on to what my colleagues have said, I agree. We do have a 2-tier health system, and our folks who are in the underserved communities are struggling to get just basic care. In my district alone, when I had met with our local dentists, we have some folks who are driving 50 to 100 miles just to see one DentaCal provider, and they're taking everyone who needs the DentaCal assistance. So we really need to work on this issue. I'm excited that we're doing this hearing early in the year, and my hope is that we can take the information that we're gathering and discussing and actually put it to use and create legislation that will move this in the right direction so that we can provide the access that we keep talking about and getting everybody onto health care, but without being able to see a doctor, we're missing that essential element. So I'm excited about this. Thank you.
Thank you, Ms. Waldron. Ms. Nguyen?
Sorry, thank you, Mr. Chair. I'm lost now. Okay. First, I want to thank Chair Bonta and also Chair Hernandez for hosting this today. I actually don't see this issue as a rural versus urban areas. This is an issue of access, period, in California. I represent an area that is very urban, but yet access itself, in Orange County has been very limited to MediCal patients and members. For those who don't know, coming to this country, my family were very poor. We were on MediCal. So I know what it's like to be on MediCal. I know what's like when my parents had to make a choice between either getting access or having to go to the hospital for the emergency room. This has been long overdue. So I want to commend both chairmen for putting this together and earlier on instead of later, so that we can have a really good discussion on what has happened since the cuts and where we need to go into the future, making sure that we do have access. Because at the end of the day, what I've always said, having been on Cal Optum and a lot of other healthcare issues in Orange County as a county supervisor, I've always said that I want to make sure that we have 10 hospitals for over 3 million people, not one. I want to make sure that you have, in Orange County, we actually increased in MediCal members, almost, I think, over 150,000 or 250,000 more members to our system in Orange County alone. And so, you're talking about, do you want just one kidney transplant specialist for 750,000 members, where they're going to have to wait in line, and by the time they get an appointment, they're in the hospital, which will cost the taxpayer thousands and thousands and thousands of dollars more than just to be able to get a specialist on board. And more importantly, these are people. We want to make sure that they have the ability to have a life, to be able to achieve and do whatever they want. And so, again, thank you for this opportunity. And I also wanted to say is I do also have another hearing on the budget as well, so I will be coming back and forth.
Thank you, Ms. Nguyen. Any other members? Fantastic. Thank you for your opening remarks. Thank you all again for being here and for your commitment to this issue. We're privileged today to welcome witnesses sharing diverse perspectives from the state, providers, health plans, and community advocacy communities. It is now my honor to call up our first panel. Jennifer Kent, Director, and Mary Cantwell, Chief Deputy Director of the Department of Healthcare Services. Thank you for being here and welcome.
Good morning. It's a pleasure to be here. I'm Jennifer Kent, Director of the Department of Healthcare Services. And I just want to say we appreciate the interest in this area. I know that just speaking from my own background, I have spent the greatest part of my professional career in and around the MediCal program. I've since being reappointed back at the department about a month ago. This is my third time actually at the department, so there is something that I consider to be absolutely core to what we do as a state, and this department and this program are really important to me, and I've spent a greater part of my time working with the health plans, working with the providers, and obviously in and around state government. So I appreciate the complexity, and I appreciate the seriousness with what you approach this program as well as we do. We are, as you noted, a department of about almost 4,000 employees. We cover 12 million Californians, which every day I get up in the morning and I think, there's not many other state programs that touch that large of a number of Californians. And so the magnitude of what we have to do as a state program is really imminent and important to me. In addition, I'm also keenly aware of the fact that, as you noted, our budget is almost $98 billion in total funds. We spend, give or take, $2 to $3 billion a week approximately, which from an economic standpoint is a really significant amount of money. And so when you have both people as well as, a significant funding source in the state, you have to take that and approach it with a fair amount of serious work and drive to make it all come together. MediCal, as I have said, obviously in Assemblymember Thurman's committee a couple of weeks ago, MediCal, and Mary's going to detail it a little bit more, but we have two delivery systems that we are running at the state. We have a managed care system for which approximately 80% of our population is currently enrolled and receiving their care through. And then we have a fee-for-service system which handles about 3 million individuals, about 20% of our population. And there, as you're going to hear today from us and from others, there's a reason why we have chosen to have an organized delivery system for the vast majority of our members, both from an accountability standpoint as well as understanding and making sure that we are providing and ensuring the best value for what we're actually purchasing. You, as a legislative body, have every right to ask what the department is spending its money on, and to ask and understand and have us provide to you value and data and metrics for what it is we're actually purchasing as a state. And so for all the things that, we want to make sure that we provide you as you talk about any kind of rate restoration or rate increase in the program, we owe it to you to actually be transparent in how we account for the care that we deliver, both on a fee-for-service as well as on a managed care side. So with that, I will turn it over to Mary, and then I look forward to your questions. So thank you.
Thanks, Mary Cantwell, Department of Healthcare Services. So there were a couple of specific questions in the agenda that you asked us to address, specifically how do we set rates in both managed care and fee-for-service, and then how do we monitor access. So I'll just briefly talk about those and then certainly welcome your questions. So we obviously do things differently for both programs. In terms of managed care, we generally set the rates using the plan's own actual experience, both cost and utilization experience, and look at their historic financial information and really utilize all of that to determine what the appropriate rates are for them. To the degree that we're adding new services or new benefits, we'll either use fee-for-service equivalent data or other plan or other information that's appropriate for the addition of that service or that population. As mentioned in the agenda, managed care rates do need to be what we call actuarially sound, and what that really means is that they have to be reasonable for the risk and the services that the plan is responsible for, or in other words, that they have to be paid enough so that they can negotiate rates with providers in order to ensure the access to the services that the plans are responsible for providing. In developing the rates, the actuaries will also take into account whether there have been changes in state law or policy, to the extent, again, that they're actuarially sound. And so one of the areas that was discussed in the agenda were the AB 97 10% payment reductions. The statute said that we should reduce plan rates to the extent they're actuarially appropriate. And in that case, what we determined was in many cases we actually couldn't make this either any reductions at all or the same level of reductions because of the fact that our plans actually pay providers differently than we pay them in the fee-for-service population. So just to give you a sort of approximate number, even when accounting for the expiration of the primary care rate increase, the reduction to health plans for the equivalent 10% reductions is less than 0.75% to their rates. And at the same time, historically over the last several years, health plans have been experiencing 3.5% to 4% rate increases each year. The other component that's really important is that plans are responsible for then, within those rates, negotiating contracts with providers. They either do that on a fee-for-service basis or they do it where they actually pay sub-capitation to providers to take on risk for either a small amount of services or a full scope risk for the services. And one last comment on the managed care side in terms of rates. We have talked to our health plans about how do you pay providers? How does that relate to what the rates are in MediCal fee-for-service? And generally across the board, our plans will report that they pay differently and higher than MediCal fee-for-service. So for example, for primary care physician services, generally, plans report that they pay anywhere from 10 to 25% higher than fee-for-service, and in certain cases, depending on the market conditions of their area, they pay even higher than that. And then even more notably, and this was the reason why we did not make AB 97 payment reductions for this service, plans report that they pay up to Medicare or sometimes more than Medicare for specialty physician services. Then in terms of fee-for-service rate setting, it's a completely different structure. How we set rates are outlined in our state plan. Generally, if there are new services or codes for outpatient services, those are set at 80% of Medicare, and then they are updated as necessary to comply with access issues or if there are changes in state law. Certain fee-for-service methodologies are actually outlined in state law. That includes things like hospitals, clinics, lab services, pharmacy, and our FQHC clinics are paid based on federal law, which requires essentially a cost-based reimbursement. And then one final point on rate setting that's very important is that in addition to these base rates, for many services, we pay supplemental fee-for-service payments. And those are sort of across the board. We pay those for certain categories of hospitals, clinics, distinct part nursing facilities, some physicians, some ground emergency transportation providers and some emergency medical air transportation providers. And then the other component that I'll speak to quickly is how we monitor access. So again, we do this differently in the managed care program than we do in fee-for-service. First, for managed care, generally both our department and the Department of Managed Healthcare are responsible for ensuring that plans provide adequate and timely access to care for our beneficiaries. The Department of Managed Healthcare monitors plans that are licensed under the Knox-Keene Act and holds plans to those network adequacy requirements. All MediCal managed care plans are required to be Knox-Keene licensed with the exception of county organized health systems. But in that case, what the department does is apply those same network adequacy standards in our contracts with our county organized health systems. Under these requirements, plans must meet time and distance standards for hospitals and primary care and timely access for all other services. Also, plans must meet wait time standards to speak to a physician or another qualified healthcare professional that's trained to screen or triage an enrollee who needs healthcare. Some other ways that we do monitoring in the managed care world is plans are subject to regular medical audits and surveys that both have elements to evaluate access and availability of covered services. We conduct annual medical audits of our plans. DMHC conducts triannual medical surveys, as well as they conduct specialized surveys through interagency agreements with DHCS for certain populations like our seniors and persons with disabilities, the rural expansion population, and our Cal MediConnect population. In addition, we've worked very closely with the Department of Managed Healthcare, particularly in recent years, to coordinate and strengthen our oversight of plans. If through these various surveys a deficiency is identified, one or both of the departments will institute a corrective action plan for the plan and work with them to bring them back into compliance. And to the degree that a plan is unable to do that, we can, and as well as the Department of Managed Healthcare, assess penalties and sanctions against the health plan. Plans are also required to submit annual timely access report to DMHC, and that includes things about wait times and enrollee and provider satisfaction. SB 964 by Senator Hernandez, enacted last year, requires DMHC to standardize the plan reporting and really have a single template. It also requires health plans to submit network data annually for review by network adequacy by the Department of Managed Healthcare. And then finally, in terms of our department, we also have other elements that we use to monitor and ensure access, including our grievance and appeals process, our quarterly network reports, and the analysis of the consumer assessment of healthcare providers and systems, or the CAPS survey, which includes elements about ability to access services. In terms of the fee-for-service program, as noted in the agenda as part of the approval of the implementation of the AB 97 reductions, our department instituted an access monitoring plan that was approved by CMS and was based on a framework based on national models. Our federally approved plan has 23 measures that cover 4 different areas in terms of access, provider availability, utilization, and outcomes. And if through that monitoring we determine there might be an access problem, we do enhanced research efforts to determine what's the scope of the problem and how can we resolve it. We also investigate access concerns that are brought to us by stakeholders on an ad hoc basis. And when that occurs, we ask for specific data, including what's the provider participation, what's the likelihood of withdrawal from the program, what are the costs that the provider is experiencing, and how do rates compare to that. With respect to AB 97, the department only has the authority to grant exemptions to the payment reductions or make other payment changes if there's a demonstrated or likely impact to access, or if there are changes in state law, and all of those have to be approved by CMS. One final thing is we are in the process of working through our renewal of our Medicaid waiver, and as a part of that, we're really focusing on improving access through delivery system transformation, as well as the inclusion of provider and plan incentive payments that really drive appropriate care in the right setting and provider participation. So with that, I will stop there, and we're happy to take questions.
Questions from members? Dr. Pan.
Thank you so much for your presentation. I appreciate what you had to present. A few questions. You mentioned that we have 80%. So first of all, of course, we have about 30% of all Californians in MediCal. You mentioned that 80% is managed care in MediCal right now, and we're moving sort of in that direction. So we still have 3 million, as you said, in fee-for-service. And you also mentioned that the managed care plan rates need to be actuarially sound. I appreciate that. And then you also mentioned that, in general, the managed care plans pay about 10 to 25% more than fee-for-service. Now, do you think the managed care plans are overpaying, or do you think they're paying the appropriate rates?